All right, everyone. This is Anna. I'm just about to turn over the introducing duties to Anita. Welcome to the PAC LTC webinar today. Just a quick reminder, we are recording the webinar. Anita, it's up to you.
All right. Hi, everyone. Thank you for joining the call today. As many of you do know, I am Anita Rafani. I'm a palliative clinical nurse specialist and one of the two clinical co-coaches for the palliative approach to care in long-term care, also known as the PAC LTC. The other co-coach is Allison Noel, who's also on the call. So a little bit about the PAC LTC. It's a 3-year initiative by the Toronto Central LHIN to support QI work in palliative care in the long-term care homes within Toronto Central. A part of the initiative is hosting 3 webinars with different topics that many of you have raised that you'd like to learn more about. This year, there are 11 homes that are part of the initiative. Last year, there were 12 homes that went through the initiative. These webinars are available to all the long-term care homes within Toronto Central to join. And if you have additional topics that you would like us to cover, please let us know so that we can include it in the subsequent webinars. Just a few housekeeping things before we get started. Please make sure you mute your phone to reduce background noise. I think Anna said right beside your name, click on the telephone to mute it, or otherwise on your phone if you can just mute lines that way. And is there a number that they have to press if they're on the phone?
They just unmute their phone and they can speak up.
Okay. Also, please remember this webinar is being recorded, so no sharing of personal health information. Also, if you get logged off, please log back in. It has happened previously that people have been logged off the system. So just if that happens, just come on back in the way you did first time. Also, there will be an opportunity to ask questions partway through the presentation, and near the end, Mary Lou and Jackie have tons of good information to present. So please, we would really appreciate it if you could hold it for either the partway through or near the end. Again, please mute all your phones because there's a lot of background noise even right now. So this is our first webinar of 2019, and I would like to thank Mary Lou and Jackie. Hi, could you just please put your phone on mute? So again, I'd like to thank Mary Lou and Jackie for agreeing to present. I know I'm really looking forward to the presentation. And a little bit about Mary Lou and Jackie. Mary Lou is a retired professor of social work at Lakehead University in Thunder Bay, Ontario, where she conducted community-based palliative care research and provided education in long-term care homes, rural and First Nations communities. In 2015, she was awarded the Hospice Palliative Care Ontario Visionary Award in recognition of her contribution to Canadian palliative care practices, education, and research. Jackie McDonald is a PSW. Jackie has worked in community settings and as a personal support worker in long-term care for 15 years. She was the PSW lead for the Palliative Care Long-Term Care Project. She was the recipient of the first Francis Montgomery PSW Scholarship. Jackie recently became part of the Northwest Dementia Network and is a member of the Palliative Care Education Task Group at Lakehead University's Center for Education and Research on Aging and Health. I'd like to welcome Jackie and Mary Lou, and I would like to pass the mic on to Mary Lou and Jackie. Thank you so much.
Good afternoon, and thank you very much for the lovely introduction and the invitation for Jackie and I to speak with you this afternoon. The presentation that we're going to be sharing integrates some of our learnings from a great many long-term care homes over the last 12 to 15 years. As indicated in my introduction, I've been working with long-term care homes as a practitioner, as a researcher, and as an educator since 1980. I've definitely seen a lot of changes in the last 45 years. I've conducted many research studies and partnered with over 30 Ontario long-term care homes all over Ontario. Palliative care and long-term care remains a timely and important topic. Long-term care is a very, very important part of the palliative care continuum of care in the healthcare system and has not received sufficient recognition and support from healthcare decision makers, with the exception, of course, of the Toronto Central LHIN. I'm delighted to be sharing the podium with Jackie McDonald again. I had the pleasure and privilege of working with Jackie on my palliative care research from 2008 to 13. I'll turn this over to Jackie to make a couple of comments.
Hi. I started working as a PSW in our community and then in long-term care. And going in there, I found that there was, first off, very little education in the PSW curriculum on palliative and end-of-life care. And then once I was hired, I learned from just experienced staff. They didn't always know what they understood or what they were supposed to do, and I noticed quickly that they had great compassion in a very gentle way, and they did things like making sure residents were always or never alone at end of life. I was the lucky person to become the PSW lead in our home on Mary Lou's research project, and this experience has really helped me grow in many ways. It helped me to become a very strong advocate for my residents and co-workers, and it was an incredible opportunity to learn, grow, and share a better way. Would not be here without the support and encouragement from Mary Lou and her team at Sarah, and I know my co-workers, the residents, and their families have benefited greatly from this timely research.
Next slide, please. And I think there's a few people in the audience that need to mute. We're getting some feedback. So in the next 50 minutes or so, these are our objectives. Jackie and I are going to review 7 processes we think are foundational to implementing the palliative approach to care in long-term care homes. Reflect on how to embed these processes into residents' care beginning right at admission, and throughout highlight the contribution and important role of the personal support workers in the process. We will share some tools and resources that can be useful adjuncts or assistants to you in implementation, and I will have provided all those to your organizers to share with you after the webinar. So next slide, please. So why does the implementation of a palliative approach to care require a really broad organizational change in long-term care? Long-term care is a very, very complex organization, and you would know very, very well that the residents of long-term care have really changed in the last 40 or so years. What we now think of, or what I started in my work career thinking of as homes for the aged or long-term care, are really more similar to residents that are now living in assisted living. Long-term care home residents are really the oldest and the most frail of the aging population. To make a broad change in the role of an organization and the culture of an organization, it needs to involve the families, the registered staff in the long-term care home, policy makers, the personal support workers, the funders, the volunteers. The whole culture has to be adapted to create a new way of thinking and doing things. It's not enough to introduce one new clinical tool or do one workshop. It's very, very complex, and I would emphasize it takes time. The work that I did with the long-term care home Jackie was working in took 5 years. The following slide depicts what I saw as the starting point in 2008-9 when we collected some initial data on long-term care. And I would suspect things haven't changed a whole lot in many long-term care homes in Ontario. First of all, residents and families of the long-term care home need opportunities to talk about their end-of-life options with staff. I had families tell me that they were anxious to have these conversations with staff, but they often felt the staff were avoiding the conversations. Either it wasn't their job to have the conversations or they didn't feel comfortable having them. Advanced care planning needs to happen much, much earlier, including conversations that focus on people's wishes at the end of life. What are their values about length of life versus quality of life? Where do they want to receive their end-of-life care? Do they want to remain in the home or go to the hospital? What are their cultural wishes? What are their spiritual wishes? Who do they want to be there with them? And sadly, these conversations often get deferred until a time of crisis. And it's extremely difficult to have them in a really thoughtful way and a way that includes everybody that wants to be included. Goals of care discussions need to broaden. It's not just about filling in a DNR order, but it's much more about all the things that I previously mentioned earlier. And it's extremely important to have an interprofessional palliative care resource team, including the personal support workers, to really drive broad organizational change. And I want to emphasize the difference between the clinical team and the resource team. Everybody who works in long-term care as a nurse, a social worker, a PSW, a physician, dietitian, they're all doing clinical care and they're all part of the clinical team. What I'm talking about here is a dedicated resource team who can take some leadership in the planning and advocacy around how to approach organizational changes. And another really important vision for change is about avoiding unnecessary hospital transfers at the end of life. I think it would be naive to say that there aren't times when it is necessary to transfer to hospital at the end of life. Their pain and symptoms are not well controlled. There needs to be some sort of intervention. But there are many times when I have seen people transferred at the end of life to hospital simply because people aren't prepared and people panic. It's either the family that panics, it's the staff that panics. It's rarely the resident that panics. So think about whether you in this room listening to Jackie and I talk today, is this vision for change resonate? You need to think about in your own long-term care home, what is your vision to change? Because that will become your starting point. The last point I would make is about the resource team that I just described. Everybody in the home has to be represented on it. Nursing, personal support workers, dietary, housekeeping, physiotherapy, administration, the resident assessment RIDE coordinator, life enrichment or occupational therapy, spiritual care, volunteer services, physicians. Even maintenance has a role to play because they're in and out of residents' rooms at all times. So everybody needs to be represented on this resource team. Next slide, please. So we really need a situation where we have top-down management support and a management sponsor, so broad organizational change can happen. A clinical facilitator who is usually a nurse or a social worker who is a champion and a resource person and an advocate and usually coordinates the interprofessional palliative care resource team that I described a few minutes ago, and a personal support worker lead. And that, of course, was Jackie's role. Next slide, please.
So why a PSW lead? There were a lot more PSWs on the floor at one time than the registered staff. The PSWs, they knew their residents. They did over 85% of the care at bedside. The PSWs had the residents' trust, and they felt a bond with them. So they had this family-like approach with both the residents to the staff and the staff to the residents. They trusted them. We were critical in the change in this project. We have the time to talk to our residents about what they liked or what they disliked, their wishes with their care. The PSWs were doing palliative care already, but they didn't really realize it. Education was a must, and they needed to empower the PSWs to learn and improve what their role was, of course, to move forward with quality care.
Next slide, please.
PSW's competencies were made with the help of Dr. Margaret McKee. She, with a group of PSWs, we put together the top 10 competencies. The first one, care of the resident, the importance of building relationships, using resident-centered assistance and observing change and reporting and documentation. Number 2, the care of the family, building trust that they were part of the team, a very important part. Number 3, care at end of life, prepare the residents, to help prepare the residents for dying by providing comfort and a connection. That making sure that they were cared for and valued still. Number 4, communication. 5, time management. 6, teamwork. And number 7, self-care, knowing the importance of looking after yourself and watching for compassion fatigue in your coworkers also. Professional development, continue learning and mentoring. Number 9 is ethical and legal issues, the confidentiality and support choices that the family and resident make. And number 10, the advocacy. At all those times when the resident cannot speak for themselves, the PSWs, their voice, acting on their behalf to ask for those things the resident would ask for themselves if they could. We needed to articulate what our role was. And you can search the tools on our website and for this. Also, right now I go into every PSW class at the college and I talk to the students on our competencies, and they always come back to me how they appreciated and learned so much from it. Next slide, please.
And there's somebody that's going to have to mute their phone, please. I can still hear quite a bit of background noise. So the title of this is Implementing a Palliative Approach to Care in Long-Term Care. And a palliative approach it includes the kind of clinical practices that are important, but it's much broader than clinical practices. It also includes a philosophy and a culture, as I earlier described. And when we were working with the personal support workers, we talked about what does a palliative approach in long-term care mean? And it really means that the staff will convey to residents, we will care for you for the rest of your life. And that needs to happen right from the time the resident first enters the long-term care home. They need to have that sense of trust and confidence and security that they will be cared for the rest of their lives. Next slide, please. So the palliative approach to care is a philosophy, and it really even precedes admission to long-term care. The palliative approach philosophy means that when people are diagnosed with a progressive and life-limiting illness that will ultimately result in their death, that they would benefit by a palliative approach. And if you listen to my words, you will see that I don't ever say that people are palliative. We don't use that language anymore with palliative approach. We say people will benefit by a palliative approach to care. The palliative approach to care is also an added layer of care to complement what you do in the way of restorative care in long-term care. Sometimes there are misconceptions that when people receive palliative care, the focus is on what is not being done. And the focus really is about doing more things and different things that complement their quality of life and really enhance their day-to-day living, their psychological, social, and spiritual care. So yes, while it's true that some very drastic interventions from a medical perspective may not be done because the situation the resident finds them in is that they will not cure them and will not return them to a high quality of life, we never say that there is nothing that can be done. The palliative approach to care, however, doesn't preclude having curative treatment. So if a resident has pneumonia and treating their pneumonia will allow them to return to an excellent quality of life and day-to-day living, treatment for infections, falls. This is all part of the palliative approach, or can all be part of the palliative approach. It's resident-focused and needs-based. So it requires ongoing assessment of the symptoms that the resident has and their functional status and their goals of care and the expectations of the course of their illness. Advanced care planning is extremely important with the palliative approach to care. Conversations about people's wishes and preferred place to receive end-of-life care are key. And these discussions are not one-time only on admission. They are ongoing, normalized as the care needs and the functional status of residents progress and change, because there needs to be changes to the care plan and often changes to the goal of care.
Mary Lou says the normalization in conversations continues, and I think that is so important because that's where a role of a PSW comes in. We're usually the ones that are talking to them and hearing these conversations and taking part in them. There's importance with empowering your frontline staff. They need to feel comfortable advocating for the residents. Education, encouraging participation in care conferences and the care plan updates. The PSWs know the residents best. To encourage training with the palliative care for frontline workers. It's an excellent course, and understanding the importance of resident-centered care. PSWs need the confidence to know and understand the changes in their residents and be able to confidently report their observations and document accurately. Next.
I'm going to stop for a few minutes, Jackie and I, and see if there are questions.
Yes, that's what I tell you, invite.
I heard someone speak, but I couldn't make anything out. You can also use the chat or save your questions to the end. I think. Next slide, please. And there's still somebody that needs to mute. So the next section of the presentation will describe that broad palliative approach to care that I made reference to, that begins right when the resident is admitted, and you'll see extends right through the bereavement section. So this figure that you see on the screen depicts the resident's journey from admission to death in a long-term care home. And it illustrates what we felt were the 7 key palliative care processes that collectively form the palliative care program. The focus of the resident's care is illustrated in the background using the colors green and yellow. The green represents the restorative care that you do every day in long-term care, and the yellow is the palliative approach to care that enhances the restorative care. They work along and go along together. They're both philosophies of care, and they both should begin at admission. The two things are blended together in the resident's care plan. Each resident's goals of care are individualized according to their health status, and care plans are adjusted often as the resident's condition changes. Overall, however, you will observe that the resident's health declines over time. So as you progress from number 1 to number 6, you'll see that the focus of the care begins to change or transition from having more of an emphasis on the restorative part, the green part, to more of an emphasis on the palliative part, the yellow part. Care also extends after death to include bereavement support for the family, the staff, and other residents. In the foreground are 7 blue diamonds. Each of these indicates a key palliative care process in the home, and we will talk about each of these in the coming slides. They're placed in sequence on this diagram from admission to death and bereavement care, and collectively they make up your palliative care program. Staff in long-term care can use these diamonds to provide them with a general guideline for when to implement each of the key processes and when to initiate the development of palliative care plans. So number 1 is around admission. Number 2 are the early conversations. Number 3 are ongoing conversations. Number 4 is the staff and the family initiate the care conference. Number 5, staff initiate the end-of-life care plan. 6, you're actively supporting around end-of-life issues and imminent death. And number 7, proactively supporting on grief and bereavement.
So the overview of the PSW role at admission, the transition, and the time of death. PSW role puts the humanistic culture into the long-term care home due to the family-like bonds that they have with their residents. And throughout this whole thing, it just goes to show you how the PSWs are so involved and the importance of the involvement that they have with their residents and the importance of recognizing these changes.
Next slide, please. So that first blue diamond, the first point is at the time of admission. And the main thing is that at the time of admission, the resident and the family are informed that a palliative approach is provided in the home. It was so surprising to me that all the families that I talked to in the project did not know or had never been told that residents could stay in the long-term care home right through and receive their end-of-life care. It had never been talked about with them. So again, I reinforce it's that message, we will care for you for the rest of your life. So the goal at admission is providing information that the palliative approach is part of the home's range of services, and to open up a conversation about advanced care planning, goals of care, and treatment decision making. And I don't say have all the conversations, and I'll clarify that, but just open up the conversation to the point where these are going to be important conversations that we will be having shortly. Some of the ways that you can support having these goals met is to make sure that in your resident handbook that everybody receives, there is a section that explains the palliative approach to care, and that the resident can choose to die at home if that is their wish, and what kinds of supports the long-term care home has in place. And they can also have written information about advanced care planning and goals of care provided as part of the admission package. Next slide, please. As I said, though, you can't deal with all this at admission. You're probably rolling your eyes and saying, are you kidding me? But it's setting the groundwork. But admission is too busy and it's too stressful, and it's not a good time to discuss details of things beyond conveying that it's part of the service. You can see if there have been previous advanced care planning or goals of care conversations. That's a question you can ask, and it's a starting point for future discussions once the resident gets settled. If nothing has occurred in the past in the way of conversations, then you know that, and it's even more important to introduce these conversations soon after admission. It's very common that families and residents are asked about DNRs on admission, signing medical directives. This is not advanced care planning and setting goals of care. It's a very specific medical directive, but we have been clearly told that signing these kinds of DNR forms requires informed consent, and residents and families have the right to be able to receive and reflect on information before signing these forms. Next slide, please. So the second bullet point, once the resident is admitted and kind of settled somewhere between admission and the 6-week care conference that is very common, is for staff to initiate an early conversation about goals of care and end-of-life care wishes. And I say staff initiate it. Our studies and conversations I had with family show that it really has to be proactive on the part of the staff to reach out. How are you settling in? What is it that we need to know to make your stay here more pleasant? And then pick up on the germs of early initiation of goals of care and end-of-life wishes. Some of the tools and resources that you have to draw on to help you with this are a set of pamphlets on residents' disease trajectories created by Dr. Sharon Kasalainen and Dr. Tamara Sussman and their team. There are goals of care resources provided by the Ontario Palliative Care Network. The Speak Up Ontario has a tool that guides you through how to ask questions. There are some terrific conversation starter toolkits focusing on Alzheimer's and other diseases by the Center for Healthcare Innovation, and palliative care brochures. But I just want to emphasize again, doesn't matter which of these resources you use, and that's what your clinical consultants can help you decide what works for you. But one of these can be a tool, and you really need to proactively reach out to the families. Next slide, please. A trained person, usually it's a nurse or a social worker who has been identified to do these outreaches, should contact the substitute decision maker and the family about 3 weeks following an admission and invite them to come in and sit down for a goals of care and end-of-life wishes discussion. You can provide them with a pamphlet on the palliative care program in your home. So that's one of the first things that your resource team can do once you figure out what your vision is and what you want to do, is create a pamphlet that can be given to families. These spa brochures are excellent tools to provide a catalyst for early conversations, and I'll show you those in a minute. And then preparing families to have a more formal discussion at the 6-week care conference. Generally, I would describe to families that we are preparing for the future, even when the resident is reasonably healthy, and trying to avoid situations of crisis. We're going to look at a few of the tools I mentioned. Next slide, please.
So this is our palliative care program brochure. It's a guide that we developed to promote the palliative care program in long-term care. And it can be adapted to your own home. The palliative care team is explained in it. It says who's on it, the initiatives that our home had, and you can even go into who your community partners are for your home.
Next slide, please. So this is an example of one of the spa brochures that I mentioned that you can give to the family, have them look over, and then invite them to come in and chat about it. The particular one I'm showing on the screen is about advanced dementia, which is the most prevalent diagnosis today in long-term care, but they have another brochure for advanced lung disease, heart failure, kidney disease, and frailty. Could you go to the next slide, please? So it's a little hard because, of course, the brochure is folded, but you'll see that on the left panel, it's what is the palliative approach. So it explains the philosophy we've been talked about to the family. It explains what is dementia and shows at the bottom of that middle panel what the trajectory of the disease is and how people are very, very gradually losing function and losing cognitive capacity, but there are not any real sudden events usually. And then the right panel shows what are some of the signs and symptoms when people are entering late or advanced stage of dementia. End-of-life signs are things like changes of condition, gradual organ failure, pain and shortness of breath. Could you go back to the previous slide, please? So this is inside the pamphlet, tips for family and friends. So with a healthcare provider, explore and discuss these options. So you sit down and you say, well, let's talk about these things. And tips for families, things they should feel free to ask about. Okay, advance 2 slides, please. So this is the next bullet. And so this is where the resident is settled in. You've had an initial care conference at 6 weeks. And this is just really staff initiating ongoing conversations about the evolving goals of care and wishes. People's goals of care and their wishes change over time, and they will change as people's health status changes. And sometimes they change in surprising ways. And if you keep asking all the time, it normalizes the conversation and allows the family to realize that these are kind of living documents. You keep revisiting things. And in particular, when there are significant changes, and on a regular basis, of course, in the annual care conferences. But that should not be the only time that you discuss these things, is in care conferences. Some of the tools that are helpful to use to kind of monitor the health status over time is the PPS, the Palliative Performance Scale. And another one is the surprise question. Would you be surprised if this person died in the next year? For nurses, there's also a tool called the SPICT, and I forget what it stands for, frankly, but it's Prognostic Indicator Guide based on the British Gold Standards framework. when you think about the question, would you be surprised if this person died in the next year? What's good about it, and especially if the team talks about that, is it's kind of an intuitive response, putting together a whole range of clinical, comorbidity, social and other factors that give an overall picture of deterioration. So it's not just really one thing anymore. And then when you answer, you would not be surprised if the person died in the next year, then you can think about, well, how to increase the support that that individual and family members are getting. Next slide, please.
The key task for staff is to recognize and identify changes in the resident status early. Important to engage the resident, the
Substitute decision maker.
And family early when status changes. Thank you. Review the medical information and revisit the goals of care and treatment decisions. And the PSWs are very key in doing this. Again, because of doing primary care, we really get to know our residents well. And at times we're their sole support. Sometimes they have no family or friends. Being a member on the palliative pain team, we are able to get information from our residents to our registered staff and doctors in regards to the decline of our residents, their health, the physical, spiritual, and psychosocial.
Next slide, please. This is the SPICT tool that I made reference to. It's just the beginning of it. But what I like about it, and doctors really like this tool because it's all on one page. Doctors like everything on one page, I have found in my experience. And it gives you kind of that global assessment. It starts out, as you'll see here, looking for general indicators of deteriorating health. And then it goes on to look at very specific indicators of different diseases that are common in long-term care. And then lastly, it invites you to review the care plan and make sure that your current care plan fits with the individual's changing condition. Next slide, please. There's the next part of the SPICT. Next slide, please. Now, you'll be familiar, I think, with the palliative performance scale. We used it in the home. It's not a perfect tool for long-term care in the sense that a lot of people, particularly with advanced dementia, settle in at 30% and will stay there for many, many months, even a year. But having said that, what's terrific about it is it's simple. It's functional, so it's not clinical, and even families can understand it and get the idea that it's there to measure change. That's what's more important, is the individual changing, and at what rate are they changing? Are they changing year by year? Are they changing month by month? Are they changing week by week? Are they changing day by day? Or are they changing hour by hour? And the faster they're changing, the more likelihood it is that their death is imminent.
We used to say that we had gut feelings that our residents were dying or that they were changing, and we couldn't articulate exactly what we meant. So by using this PPS scale, we could see the changes that our residents were making when we observed them, and we could, when we couldn't articulate them, we would be able to say our resident was 40 yesterday and now their PPS is 30. We knew that they weren't taking part in their care anymore, that they're not getting up at all or they're not eating as well and they are just sleeping more. So that should put a flag up to our registered staff to call in a meeting with the family. And for us, it was really important because too many times our residents died without family members being able to get there to say their last goodbyes or to talk to them. And this helped. It was important for us as the PSWs, that the registered staff and the doctors used the language, they used the PPS, because there was a lot of pushback on it from the staff. But when they did catch on, it was very valuable.
I'll just add to that, in our study, when residents were admitted, usually they were somewhere between 50 and 60%. And then of course, 0 is death. Usually 30%, 20% is when you see people entering that sort of imminently dying end of life phase. Next slide. Okay, so this is bullet point 4. And this is the big change on the diagram, where you really, although both the palliative approach and restorative care have gone hand in hand, you really are shifting the goals of care to be mostly focusing on the palliative care needs. You really want to revisit the goals of care, and there's a number of tools and resources that can help you. One of the things that we developed was a questionnaire that can be used with families that identify 23 things that and invite them to rate their importance. And they're things like the compassion of the staff, management of the illness, communication and decision making, the relationship with their doctors, and how they want to be involved in the care. So it's a nice structured way of inviting input from the families about what they think is important. And it is also a good time to introduce a hospice volunteer if the residents and families wish. We had good success with partnering with our hospice volunteer visiting group. Next slide, please.
So the PSW role in care conferences are important. The PSW, I have found with my experience, was that we were able to connect the whole team together. Sometimes the dietary would make comments, but it was we were able to fill in different things about exactly how they were eating, whether they were choking, and it was important with the rounds, the pain and symptom management, the rocket rounds that we had daily. It was a chance for us to help our residents by putting this information right in the forefront. It was very beneficial, but we did have resistance with management. The PSWs need to be a part of this. The pain management meetings, they were sometimes not attended by the PSWs, and therefore some information was missed because we weren't there. Due to the shortage of staff right now with the PSWs, there was a few different issues there. But again, I have to say, without support from management, bringing in the PSWs, it just was making it a lot harder.
At this point, the fourth spot where the big changes taking place, it's really valuable to have a dedicated care conference that brings the family, the staff, and even the doctor, but depending, but to have a dedicated care conference to really answer all the questions. Next slide, please. This step is when you really know that death is imminent, and you're shifting to what I would call an end-of-life care plan. It's focusing a lot on symptom management, making sure that the resident remains comfortable and as much as possible pain-free. You need a crisis plan in case there's a medical emergency to avoid what I mentioned earlier about someone panicking and calling the ambulance. There are things that are predictable that don't have to result in panic. The resident family need a lot of support. The PSWs, as Jackie described, need to monitor the changes because they're the ones most likely to see the subtle changes, and to address anticipatory grief. So the anticipatory grief is the grief people feel in advance of the deaths. And there's a lot of important work that can be done there. A couple of tools and resources are the comfort care bag and a brochure called Food for Thought, which is intended for families to understand why the resident doesn't have an appetite and doesn't want to eat. Next. Oh.
I looked after a lady that had an advanced cancerous tumor on her head. That was very painful. And there was no curative treatment anymore. We couldn't believe that she was still with us, and let alone talking and carrying on. I asked her one day, she was mine, and I got to know her very well, and I asked her one day what was keeping her with us. And we sat and we talked about dying, and she talked about dying one day and being with her husband once again. And so when I asked her why she was still here, like what was holding her here, and she answered to me that it was her daughter. Her daughter didn't want her to leave. Her daughter came every day. And so we talked about that her daughter would miss her and that they had wonderful memories and she would always have them. And she was quite content to sit and talk to me. When I left the room, I saw her daughter coming down the hallway, and I pulled her aside and told her about a conversation. The daughter did thank me, and she went in and talked to her mom. She went to her mom's room and had this wonderful conversation about her mom dying. And she told her mom that she loved her and that she would miss her and that she wanted her pain to stop. I noticed the difference in our resident after. She was more at peace, and she had ended up dying not long after that. But she needed that permission to let go. So when some of our residents have no family support, and we often at the end of life tell them that we value them, that we love them, that we'll miss them, but they should let go, that everyone will be all right, and they need this permission. With the comfort care bags, we used to bring things into our residents' families, a newspaper or a cup of coffee when we knew they were sitting bedside. And the staff came up with the idea of this comfort care bag, and in it there's all different sorts of things that the staff was donating, like candies and Kleenex, and you know, if they were spending the night, mouthwash and bars of soap and reading material. We started personalizing it. Some staff were making little angels. Some were donating rosaries, and we always had paper and pen, and a very important part of it was the pamphlets. The information on what was happening to their loved ones. The first bag that I gave was given to a lady that was actively dying. It was given to her daughter, actually, and the daughter started going through the bag, and I would explain to her what each thing was and why it was in the bag. And she pulled out a cloth that one of our dietary aides had crocheted. It was a dishcloth. And all of a sudden her mom sat up in bed and took the cloth out of her hand, and she was Ukrainian, and she started talking in Ukrainian to her daughter, and they both started laughing, these belly laughs. And I asked what was wrong, and the daughter explained to me that her mom used to crochet these, but they were so much bigger and better. And so they had that laugh and talked for a little bit. that night the lady died. And I've often thought back to that first bag that I had given and that connection that the daughter and the mother had over the dishcloth and that hard laughter that they had, and it really made me feel good.
Okay, next slide. So we're going to have to wrap it up, Jackie, in about 2 or 3 minutes. So we're going to have to speed along. But in this end of life stage, again, it's really important to proactively prepare for what you can expect and have discussions with the residents and family well in advance and support them well in advance to just prevent that panic that you all know happens. 6, please, next slide. So this is the time of death, when the individual is dying. Obviously, the resident and the family needs support. Jackie, you can just very quickly just mention those 3 things, but you're not going to be able to explain them in any detail.
Yeah, we have butterflies as a communication to staff that are put on the doors. And we have a dignity quilt that when our residents die, we put this beautiful quilt that was donated over them to show our respect, and staff walk them out. It's very important to us. The memory box were given to residents. It was donated by Hospice Northwest to put their belongings in because we were giving them garbage bags or 10 boxes to put their things in.
Next slide. That's just the memory box, shows you what it looks like. Next slide. So just really be sure that there's a lot of support available, that no one dies alone, that no one's left alone. Communication is the key here. People are upset when they don't know what's happening and they don't know what's normal. They don't know if their loved one is in pain or suffering. They need a lot of reassurance. Proactively respect culture or faith-based practices and rituals, provide a lot of time for the family, and really prepare them for the next steps. Next slide, please. So the last phase is support with grief, and it's important to remember that there are 3 groups of people that need support. The family needs support, the other residents who will go for a meal and see that someone has died, and staff need a lot of support. There's a concept in the literature called disenfranchised grief, and what that means is the grief that people feel but it's not recognized. And they're you know, the family, we recognize there'll be grief, but the staff have very, very strong family-like bonds that, as Jackie described. So some of the things that were implemented, Jackie, you could just run through that list really quickly.
We have our sympathy cards and placemats that we use that were really important. The staff feel that grief when our residents die, and just to be able to sign a card and send it out means a lot to them. The placemat is more for the residents, and we place it on their table where they sat, and it helps bring conversations. And a big one is the peer-led debriefing for staff. That was very important. We would have our residents that we really do love, and they would die, and somebody else was in their bed, and it didn't give us a chance to actually grieve for them. And so we started doing these peer-led debriefings that really helped with morale around the home.
Next slide, please. So there's a toolkit to describe the peer-led debriefings, and the training for those took 20 minutes. And it was done at the end of a shift or sometime when it was practical to get together. Next slide, please. So we talked about the fact that you need to recognize there are 3 groups and that everybody's an individual, and you just really have to listen to the advice of your family council and staff who know them well. Next slide. So just to wrap up, initiating organizational change requires a team of staff to champion change. I feel so strongly about the importance of that resource team. The palliative approach is a philosophy. It's not one thing you do. You need a top-down leader to meet a bottom-up initiatives with the staff. And like Jackie said, and it's so important, the staff are already doing this work. It's just when they have some support and education, they feel better about what they're doing, and they feel more empowered and supported. And a palliative philosophy, I don't think, can be imposed by regulation. It really has to come from within the home and within the culture. Next slide, please. So that's our website, www.palliativealliance.ca. Everything that we talked about today is on that website. All of the information about the resources and how to go about doing things like post-led debriefing. The woman on the right in that photo with the long dark hair, that's Jackie that you heard speaking again today in her home, along with the manager of the home that she worked in and a resident in the home. So I know we're out of time. Thank you so much for your attention. And if you have questions or comments, Jackie and I can stay on the line. If you have to leave, you can send them to your organizer and we'll do our very best to answer them.
Hi, Mary Lou, it's Anna. Thank you so much. And Jackie, thank you so much. We had a question in the chat from Dorothy, and she asked about strategies for empowering and engaging PSWs. And you kind of touched on that a couple of slides ago where you talked about support and education. Did you have any other specific strategies for engaging PSWs?
I'm going to let Jackie answer.
You know, that was a really tough one. When I started as the lead with the project, I was really hit with a lot of negative comments. And I had my managers were really wonderful, also with the whole team from the project. But I really saw early on the importance of having that go-to person. And it was very quickly that I knew who was going to support me. And I would gather up more PSWs, and doing it that way, we had a lot more rather than just me that would gather information or bring forth stuff. And I think having that, I can't stress that enough, without support from your managers, just that acknowledgement is very important. And just strong people that really do believe in it. I believe that PSWs are that kind of a person already, and sometimes we just have to bring it out stronger in them.
I think from my perspective as someone who was facilitating, I think it was really recognizing the important role that the PSWs played and making them feel valued. In our initial environmental assessment, PSWs described themselves as the bottom of the barrel, at the bottom of the hierarchy in long-term care, and that nobody listened to their input. In fact, not even they didn't listen, they didn't even ask them. So having the PSW competencies was very valuable because it allowed people to appreciate how complicated and important the work that PSWs did. It was no longer invisible work. And so that was important. I mean, nurses and doctors and social workers have competencies in their work. Why wouldn't PSWs? Secondly, having them at the table in the teams, in the care conferences, as part of all the education, doing the PPS, just modeling that culture change where PSWs are valued, that's what I think empowered them over time. But Jackie's right, it didn't come easily or quickly. There was resistance, even from some of the PSWs who were kind of immersed in a bit of a negativity. But that changed slowly over time. But it did, as I said at the beginning, take 5 years.
Thank you so much. Does anybody else have any questions? People are just sort of backing off the call because I'm sure they have to go to other meetings and commitments. But does anybody have another question for Jackie or for Mary Lou? Okay, I will assume that we're good for now. If anybody wants to email Suzanne or me, Anna, with questions, we'll see if we can get some answers. Mary Lou and Jackie, thank you so much. This was really wonderful. You've given us lots and lots to think about, and we're going to go forward and change everything.
Wonderful.
I wish you well with that. It's very important work.
Thank you and goodbye.
Bye.
Bye.